Mr. Chairman, ladies and gentlemen, real pleasure to be with you in the UKA conference, and I'll try to speak about the results of unicompartmental knee arthroplasty, how consistent are the results, and the quick recovery following this procedure. But before I start, I have a question to ask, and for everyone to think about is osteoarthritis a reversible process? Is it a reversible process? Is someone with osteoarthritis can be turned into someone without osteoarthritis? This is a question to just think about it while we are talking about what are we going to do with patients with medial compartment osteoarthritis. And to set the scene, I'm going just to define what is the point of discussion. What are we debating, really? And then we'll talk about patient selection for uni, and finally, outcome and long-term survival. So, to set the scene, perhaps we cannot reverse the process of osteoarthritis, but we might be able to alter the progression in some patients. So if you have someone like this with a varus malalignment, it is an extra-articular deformity, and you perform a high tibial osteotomy, you might be able to alter the progression. Okay? So, high tibial osteotomy is a highly successful process in a selected group of patients. And the caveat is, and look at the points that have been listed on the left side. These are patients who are not satisfied. They don't have good long-term survival with high tibial osteotomy. Patients with Killegren grade 3 or more, high BMI, intra-articular deformity. There is no extra-articular deformity, but rather the patient has developed the varus as a result of the collapse of the medial compartment. These are not good candidates for high tibial osteotomy. Stiff knees, old patients, and incomplete correction of deformity. These are the risk factors for the early failure of osteotomy that have been listed in the literature, and that's why high tibial osteotomy might not be suitable for this group of patients. What we are talking about really are patients with bone-on-bone on the medial compartment. This is the area of debate. That is what we are debating. If you have someone with bone-on-bone on the medial compartment, intact ACL, intact MCL, what would you choose for him? High tibial osteotomy or unicompartment? And these are the results of unicompartment knee arthroplasty that you're going to see. So, if you have someone with bone-on-bone, I think the unicompartment would be the answer for him. And before proceeding, I would like you to have a look on this slide because it looked at the outcome of total knee arthroplasty when performed in young patients. And when you look at the results of total knee arthroplasty in young patients, overall satisfaction rate is around 90%. But if you look deeply into the subgrades of functional outcome, function that is dependent on knee flexion, getting in and out of the car, going up and down stairs, only the satisfaction rate is around 66%. This is for total knee arthroplasty. And this is perhaps related to the kinematics, perhaps related to the loss of ACL and MCL function. But in unicompartment knee arthroplasty, you are preserving the ACL, you are preserving the MCL. In fact, they are prerequisites for the patient's selection to have unicompartmental knee arthroplasty. Because when you have around 25% of patients with knee arthritis who only have anteromedial osteoarthritis, I think this is the place for unicompartmental knee. If you have someone with intact posterior cartilage, intact lateral compartment, and we have always talked about the patellofemoral joint, intact cartilage on the patellofemoral joint, and there is now expansion of the indication for unicompartmental knee. Patients with mild changes over the medial facet, who don't have erosion of the lateral facet might be good candidates for unicompartmental knee arthroplasty. So these are the suitable candidates when you have minimal changes on the patellofemoral, but not advanced arthritis of the patellofemoral joint. Corrective deformity, obviously, is one of the indication. And as we are expanding and talking about unicompartmental knee arthroplasty, you may look at this X-ray and find that the patient has chondrocalcinosis, but if you look carefully intraoperatively, she had intact articular cartilage on the patellofemoral joint. And the only erosion was on the medial side, so she received unicompartmental. And you see the translation of the meniscal bearing intraoperatively during flexion and extension as the point of contact moves from anterior to posterior with flexion. But look at the post-operative function of this lady who had unicompartmental knee. This is post-operative X-ray. And even these patients can benefit quite nicely from unicompartmental knee arthroplasty with very good range of movement post-operatively. So just highlighting the idea of constitutional varus, because patients with constitutional varus have developed arthritis later on in their life. If you return them to the neutral, might not be happy. In unicompartmental knee, if you have someone with constitutional varus, assuming that he has corrective deformity or corrective varus, these patients might remain in varus alignment post-operatively. And this is more functionally satisfactory for these patients than if you correct them to a neutral axis. What is the effect of surgical case load? Perhaps you need to do more of these unis to get good results. But the story is, it's not only the unicompartmented that would need good surgical case load. It's also the total knee arthroplasty. Because I performed uni for her, and I didn't perform the other side. But you see early failure of her total knee arthroplasty. So she had a revision of the left side, and the uni is still surviving and functioning very well. So she had an RHK on the left side that was revised, and the uni on the right side that's still functioning well. Outcome was uni, early recovery. You see patients coming back to remove the sutures with full range of movement. They are very satisfied. Incidence of complication, myocardial infarction, CVA, infection, mortality, all what's around surgical intervention in terms of complication is very low. You see patients with high BMI as well. And they are achieving very well and good range of movement at 4 years post-operatively. They are satisfied. But you have to remember that patients with BMI above 35, 40, they have a higher rate of complication in comparison to others who are around 30 BMI. How about return to sport? Well, this is a study that shows that those who practiced a kind of sport pre-operatively, 92% of them returned to sport at 4 years post-uni compartment arthroplasty. Elderly population, if you have someone with octogenarian, perhaps it's very safe or less risky for him, I would say, to have a unique compartment if he has a medial compartment osteoarthritis and achieving good outcome post-operative, as you see with this gentleman. The outcome with young patients, we have a survival at 10 years of around 92% for patients with at average age of 54 pre-operatively. So the survival overall in young patients is quite satisfactory, and the incidence around the surgical intervention in the elderly population, octogenarians, are less than total knee arthroplasty. Overall outcome might be less than total knee in terms of long-term survival, but you still have around 90% survival rate at 10 years. So the take-home message is, if you have someone with bone-on-bone on the medial side, with intact MCL and the ACL, I think these patients would better be served by having a unicompartmental knee arthroplasty than a high tibial osteotomy. So consider it because it has good post-operative outcome and good long-term survival, and you do it to survive not to revise it afterwards. And thank you for your attention.
Thank you.